All right, it's being recorded. Thanks, Drew. So this is a pleasure to be able to introduce Dr. Obremskey. It's interesting because as I was thinking about this last night, and even this morning, I did this Ortho Joe podcast with Mark Swankowski and Mo Bandari, is how intertwined the world is. And so I just learned today that Bill, as an undergrad, was frat partners with Dr. Vale, and did not know you guys were in the same fraternity at Duke. And then that continued, the friendship continued, I guess, in Duke when you were a medical student, and Ed, you were a senior person, more senior person for him there. Yeah. And so after that, I realized also Mo says, oh, well, nice to see you. And you did your residency in Seattle and had a chance to go by there. And then Mark Swankowski made sure to say, well, tell Billy I said hello. And then I met you when you were in Chapel Hill. So you were an undergraduate, or you were a medical student there, but I think we met when you were joining the faculty there. And then you went to Vanderbilt, which you've been there ever since. And we're really lucky to have Bill here. He's been a leader globally in orthopedic trauma. And he's talked last night at Journal Club about the different metric studies that he's personally been leading as the PI, but all others that he has as well. He's been the chair of the membership committee for the OTA and the evidence-based medicine committee for that organization. And this particular topic, he's been a leader also internationally. There's a fracture-related infection work group that is a sort of an international consortium. They've been very productive and published multiple papers on the subject and tried to shine light on fracture-related infection. We were talking yesterday about how Bill has now taken this to the World Health Organization as well. And so we're privileged to have you here with us. Thank you so much, Bill. And you're a friend to many of us already, and you're certainly an area that you're an expert in, and we look forward to hearing more about it. Thank you.
Thank you.
Little applause.
I think the privilege really is just in being here, and thank you for the opportunity. It's always invigorating, and thank you to the residents who took me out there. They've never unleashed me at a number of these with just unsupervised with the residents. So that was very energetic and entertaining. So thank you for a good dinner in a good place. But I'm going to talk really about fracture-prevented infection. I don't have any disclosures of anything pertinent. But San Francisco has been an important. I've had two uncles who had their entire career here. My sister's been here since the early 90s. I got engaged here. And so it's always been a great place to come back to. And I've already made plans to come back in July. And we've got some activities with my old friends with Sam scheduled already for the next visit. So I look forward to that. But it's a great place. And I've known Dr. Vale for a long time. In 1980, I think I said, and he was a BME and a really smart guy, the senior, and also a writer and famous all over campus. And his little brother was my classmate also, and so I've kept in touch with them over the years. And and he's such a good writer and so smart that when I had a really sticky issue that I was writing a paper on how to assess quality in healthcare societies, and so who did I go to but Dr. Vale to help me write this, which I think is hopefully a model for many centers. And UCSF has done a great job of sort of threading that needle as far as I can tell. And I'm amazed after 16 years that he's decided to step down. But all good things must come to an end. But thanks, Ted, for a lifetime or career of friendship and mentorship and advice on things. And Ted, I've known Ted a long time. I said we have a mutually best friend, Doug Dershel, and I think we've had a long time connection. And I really thank Ted for the opportunity to be at IOTA. It's a great opportunity, and his brainchild took 10 years to put together. And just this last December, they had the inaugural meeting, and I think it would give me a chance to talk again on fracture-related infection. But it's just, I think the vision is what's important. And the nice thing about trauma is we're all in this together and we don't have some of the internal competition, and it's about making the world better. And, 5 a.m. call, which he reprieved me from having to attend this morning. We're gonna try to set up a registry so international people can have access to better information for improving quality of care. And we're gonna help drive that in the future. And he got some really sweet wooden shoes he might share with you from the folks in Amsterdam last December. But also, as I said, it's a little intertwined. I've known Mo since resident, and he was the pesky junior resident that asked, and we got tagged together. I think 3 out of the 5 rotations you were my junior resident on, so I got to spend a lot of time with Mo. And I hear, and it warms my heart that he's a fan favorite, as he was described, and that he continues to ask very interesting and challenging questions, I think, as we maybe just heard. So some things just never change. And Sam, these are 2 of the most thoughtful orthopedic surgeons that I know, and that's saying something. And I just really respect them. And it was such a pleasure to spend time with Sam yesterday in clinic. Previously I'd spent half a day with Mo. The difference between San Francisco and Tennessee is Sam's in there, and I don't think he got nice bottles of wine. He got gift certificates to 5-star restaurants, and I get chickens and pigs and moonshine. It's something, but I think it was just because, and he was like, I don't deserve this because you care, Sam. I mean, Sam cares, and he does a great job. And clearly people really were happy to see him, even in some of their worst moments. So thank you to all of you for the opportunity to be here. It's an honor and privilege, and our future is bright with the young, bright minds. And I'm very confident of that. And often we hear a lot, but I grew up in a small town in Indiana, in the cornfield, and being here with Zoom, and I went to Duke for undergrad and med school, and got a master's in public health, which was really a great investment in my education years ago and led to a lot of advantages from the research standpoint. And then trained at UW, as you heard, and did my time in the Air Force. I was an Air Force general orthopedic surgeon, and then did a fellowship with AO, and then went back to UNC for 5 years, and then came to Vandy almost 21 years ago. And it's been a great place to be an academic trauma surgeon. And I think the whole principle is trying to make things better and educate. And that's what I've really enjoyed, is the education to pass it on, to learn, teach from our mistakes. I think we saw that, and we have lots to learn. One thing I think I'm really proud, we put together this, nobody's doing books anymore, but this was really the first why book. I mean, Mo is a why guy. I was a why child, and this is a why book. And it's in its 2nd edition, but it's the thought process of why we make the clinical decisions we make. And it was sort of fun to do from that standpoint. And then research is how we get better and why. And if we don't like the questions that you give us, we all need a new job. Okay, so keep asking those questions. And many of the things I'm going to talk about are things that started when I was sitting in your seat and asking those questions. That didn't make sense. I mean, why don't you let people walk on ankle fractures, or some of those things which are now coming to fruition, and a number of grants. And hope you continue to question everything and question us as you go. But you can't really do this unless you're really focused on the quality. And as chairman of the evidence-based medicine committee for 10 years or so, and for our department, that there's always things, and defining it is what is really hard, and why I really struggled with that. And I had Tad sort of help me try to at least give some guidance to other people around the country of how you might assess that in the future. Because I hope that academic centers like us, we own quality, and we're responsible for quality to set the standards for patient care. It's not about making money. It's about, you got to make money. And which is why I did a business degree 10 years ago, just because without that, you can't create this environment of putting the profits into research and education and your education. And AMCs, academic medical centers, are really special places, and they're going to struggle, but I hope that they survive, because, even though the T-Rexes currently, you have to morph, and UCSF is making a great attempt at morphing into the new healthcare world. And we're going to be accountable for cost. The MEOC, I run our supply chain cost across the institution, and just trying to keep costs low and quality high. And so that's really why I did the business side of the degree. But my real disclosure is I've made lots of infections as an orthotrauma surgeon, and I've spent a lot of my last 5 years trying to figure out how to prevent them and treat them if they do occur. And these are all open access journals. One of the principles is we try to make all this open access available. And so all these articles, these 2 are 2 of the articles that the AO, the international group, helped put together in a structural process. And many of it's that Parvizi put together a group of trauma surgeons in addition to the total joint people a few years ago. And I led in publishing that in JBJS. And so these are all open access documents that I think help give you some guidance on clinically relevant decisions on how to prevent and treat infections. Because the reality is bacteria has been here before us. They'll be here after us. They're bigger, faster, smarter. There's more bacterial DNA in our bodies than there is our own DNA. So you shouldn't give up. You just got to keep figuring out how to work smarter. And you're going to have much better, precise mechanisms for diagnosing and treating and getting and hoping to win some of the battles, because we're never going to win. It's just got to respect that opponent. It's the right time of year for this, although neither one are playing anymore. But I just think it's a reasonable analogy. You have to respect and you have to work smarter on how you're going to prevent problems and take care of them. Because the reality is, this is WHO data, that MDR, multi-drug resistance, is going in 2050, that's your lifetime, your career, more people than cancer, diabetes, and current trauma. And so it's just going to outstrip all those things unless we figure out how to do this better. So this is probably real data and a real worry. So, and these are all things we talked about, that open fracture. These are all the things we did. We operate them in the middle of the night. Everybody had an X-Fix. You used a Pulsivac. No open wound got closed. And what do we do in 2020? None of those things. So hopefully 30 years, you're standing up here talking to somebody and doing none of the things that we're doing now, and everything you're doing is better. And I think you saw it earlier, because maybe an ounce is better than a cure. Or, I've always sort of thought about it, stack the deck. It's all the little things you got to do. And as I watched this movie last week, I mean, you can be nihilistic that this is, nothing really matters. I don't know if you've seen this movie, but it's got 7 Academy Awards. But it's not that nothing matters. It's that everything matters. This is the message right here. Everything matters, and it matters a little bit, and you just have to do everything, and they all have an impact on the long-term outcome. So this is really the message right here. If you see that movie, think about it, or the other. There's been lots of articles on this. This thing did in JBJS started when I was a medical student. Started keeping folder of all the stupid, when the nurse told me to scrub at the sink at Duke for 10 minutes, and I asked her why. That did not go over well, by the way. But just start to thinking, what are all the things that we do? And there's a lot of stuff out there. I'm not going to talk about most about this, but I'm going to talk about this, and I'm going to talk about the other stuff we can do in perioperative management on patients for preventing infections, because we'll never win, but trying to get to zero is okay. And industry's done it in a number of things, and we can try, and it's a worthy fight to try. And with the first is just diet and our patients. I mean, this is literally one of my patients' trays not so long ago. And how do you heal if this is what you're eating? And in Tennessee, last several days, I guess you may have a vitamin D problem here too, but 40% of people in Middle Tennessee this time of the year are vitamin D deficient. We don't know it helps, but it makes some sense that it helps in terms of getting bones to heal and things. And smoking, I used to just yell at people, but we have now developed a system for doing that. I mean, the literature really, and I used to hate people getting patches. I was wrong. Now that it's okay to get the smoking cessation. If you don't have one here, hopefully your system can develop, or you can help them develop it. Because getting them to quit smoking is really important in preventing infections. And this is what in Mid-South, people, they've been eating biscuits and gravy and fries and fried chicken for 50 years. And is it a surprise that if you break this ankle that it may not heal? Or that if you break that tibia, it might get infected? Or somebody doesn't think about that and they do this, and then they do this, and then they get the amputation because the reconstruction is not feasible. So think about those things as you meet patients along your life, of what's the likelihood they're going to heal the cut you put on them. And sometimes primum non nocere still is true. And there's some people maybe you shouldn't operate. Or what we sometimes do is get vascular. Okay, you stent them and I'll fix them. Or I'll fix them and then you stent them. And we do that combined sometimes. And perioperative glucose, this came about when they were sticking my fingers every 8 hours that's a different story. We may tell that later. But hyperglycemia is a problem. We've shown in retrospective and prospective studies in multi-trauma patients and in isolated orthopedic problems that perioperative hyperglycemia is a risk factor for deep infection equivalent to having an open fracture. So if you don't have a process for that, we have a whole algorithm and process for monitoring patients' perioperative hyperglycemia on our trauma patients, the same as the trauma and the ortho trauma patients, because it's real. It's probably true in total joints too. We don't know what the cut point is. We've tried to figure out what the cut point is, and nothing really seems to have worked. Another thing simple like oxygen. In prospective studies, oxygen has cut down on superficial infections. The decrease in deep is not, and I just read the secondary analysis, and so it's less maybe for the deep, but certainly helps a little bit. And in ortho trauma and everything, I mean, our total joint friends have taught us that decolonization is good. It decreases infection risk. But do we do that with all of our pilons, plateaus, non-unions? Not always. I mean, there's some things we can do that have literature-based and is actually a WHO recommendation to decolonize patients for orthopedic procedures. But we don't always do it. And this is my biggest frustration, that we have level 1 data or recommendations that we or even I just ignore. And I think so we've got a lot to learn, because literature is out there. We just don't always pay attention to it for decolonizing. And in our trauma patients, we know that, around 10-15% are MRSA colonized, and the WHO recommends that, but we don't always do it. So I think there are things we can do to really help those patients. This was a little more pertinent. We spent a lot of time looking at open and closed fractures and what's the right prep. There's lots of science out there, but this was just published a little bit ago in Lancet. A nice publication saying it doesn't really matter. So whether or not it's betadine or ChloraPrep or alcohol-based or aqueous-based, it doesn't seem to matter. So again, use something and probably be consistent with it. Irrigation, when we used Pulsevac, you had to use 9 liters of Pulsevac. And what we have learned, the flow trial, and I really thought I was wrong, that adding chlorhexidine would help as a surfactant, bind up the organic material, get away the bacteria. But actually, it increases the infection rate using soap. So we've gone away from doing that. And that, with the flow when they were designing it, I really thought they had a bulb syringe as well. I lost that argument, one of many. But I think so 3, 6, or 9 didn't really matter, but don't use soap. And other studies show don't use high pressure. It causes bone and soft tissue damage. And you get a late bloom. Some really great biologic studies looking at fluorescent bacteria that they bloom late if you pulse them into the healthy tissue early. So we've stopped that as well. So no soap, no high pressure. This is, I think, a hot topic. I don't know what you all are doing here, Tad, but these irrigants, there's lots of expensive ones, Bactisure, Experience, or dilute betadine. And I would say that there's been some reasonable data that it might help and work. It's hard to do in our trauma wounds, and I try to do it sometimes, particularly in our hemis and some wounds. And just this week, Metric has decided to do this in our acetabular fractures, because they're still in the obese. It's a 5 to 10% deep infection, and that's a huge problem. So you're worried about a 0.05 infection rate. We're worried about our 5 to 10% infection rate. But this is some of the basic science that really it does decolonize, and it's got to have something to do decolonization. The basic science is pretty good that these are effective. The clinical science isn't quite sure, and I think we're figuring it out. And this got sent to me yesterday by a rep who wants to meet with me to talk about selling me Bactisure. And I said, well, and the question I asked him, well, please have your scientists talk to me about how you're better than betadine, or, which seems to be the same in that other article and this article. And because this is the article that they were referencing. Oh, the problem is there may be some conflicts of interest in some people. I don't know if there are. I don't know these people, but I just use with a critical eye. People are going to be selling you stuff that's going to work, but be evaluated. Be critical of the evaluation. So local antibiotics work. Okay, it may be local antimicrobials. This was the Parvizi group that we made that statement with significant maybe decrease in infection rate. I would say, and the Metric group has shown that works for gram positives when they use Vanco in the Vanco trial. Overall, it didn't decrease significantly, but it took the gram positives down from 7 to 3. Well, that's pretty good. Gram negatives were the same. Although Lori Donners was doing this 30 years ago, right? And he was right. And he didn't show in a prospective, but he was retrospective study that gentamicin. And I think tobramycin is a better choice. And there were part of a current tobramycin injection local study in open fractures because it has gram positive and gram negative, and it sticks around longer than the fairy dust, which goes away and is gone in 24 to 48 hours. Tobral stay 3 to 5 days. Again, the race for the surface. What are you going to use? And Metric's been doing it. They've been doing it, and we're doing it now at Tobra and Vanc, or Tobra and Pelons and Plateaus, which have our 10 to 15% infection rate, and Sexton and open fractures. The 3Bs, this may work. My guess is it's not going to make a difference because there's too many other factors that are really important, like our disaster patient, that adding antibiotics. But the decolonization probably is really important. We wrote this in JOS a few years ago, and this ladder is just a way to think about it. And just in your mind, how are you decolonizing? No matter the wound that you are, and these are open wound models, but it applies, I think, in closed and open wounds. But it just gives you a sense. These wound vacs, they work, but maybe not so good. They decrease gram negative, but not gram positive. Whether silver, yet adding antibiotics really logarithmically begins to decrease the bacterial load that's present in the at-risk wound. Just a way to conceptually think about it. Because local antibiotics, you're going to use them, or local antimicrobials. Currently, we only have antibiotics, but powder, it goes in. There's a vast way of delivering them, and but in beads, this is one of my pet peeves, and Sam heard it yesterday, that we've used beads, and I have used beads, but it's a terrible way to deliver antibiotics. Only the outer couple of millimeters of that elutes. It's 5 to 15%. Where's Christina? What then? It's about surface area. So spheres are the most efficient way to have a lot of volume in a small surface area. So it's about, you need a plane. So you need pancakes. You need to forget about the beads. You need pancakes if you want to elute antibiotics. And it's a basic geometric. When one resident sort of challenged me on that, he was like, well, why do you use a sphere? And I'm like, because it's the way, and I was wrong. So with all this dogma that we have, you really need surface area if you want to elute antibiotics. And the amount, I think if you really want to get rid of a lot of antibiotics, I think, as I said earlier, that I'm using a lot more calcium sulfate because it's maybe the best we have now in the chronic. Other of these bioglasses, you're going to see they actually are antimicrobial. The thing you're going to see, which I think is interesting, are some of these polymers, which you can dial them up. You can have lipid and a polymer and then drug of some sort. And it can be engineered to elute in a variety of different, either acutely or over long term. I think for drug resistance, you don't want low degree for a long term. That creates drug resistance. So when we're going to see these, is going to be high peak, comes down fairly quickly in time for the eukaryotic cells to populate our implants, whether it's total joints or spine or orthopedic trauma implants. Because in orthopedics, we have big wounds, compromised patients at times, and large metal load. I mean, that's a full, pretty much across a lot of what we do. It's or load of some sort, whether it's poly. I took a suture button out of a woman who's been in 20 years on Sunday night, who was now infected for unknown reason after 20 years of being in there. So these foreign bodies can still become infected, and they may need something to help prevent them. The next thing that's going to come are the hydrogels. And Metric also last week, we decided our next Pelon Plateau study is going to be with gentamicin in use in hydrogels. I think it's great for a smaller area. It smears all over. It stays longer than powder. And I think it can be really in the rabbit, the basic science data. It's good, it's effective, and it's probably ready for prime time in December. I saw the final product for the handling characteristics. It's really like a thick gel, and you can smear it all over the wound and all over your implants are played at the time. Even coat a nail before it goes down. But you're going to see different things. I think that they work. I think you're going to see, silver's been around, but some of these newer substances, proteins that kill prokaryotic cells, not eukaryotic cells, and alkaloids. The probably next thing will be the alkaloids from naturally occurring processes. These sponges make an interesting alkaloid that's cytotoxic as well. So some sort of antimicrobial will probably be what you'll be using 20, 30 years from now, and not so much an antibiotic because of the concern for resistance. Stability is really important. I'm not talking much about that, but Ted is an aficionado and expert on the history of Stefan Perrin, and this is an ode to Stefan that I think is really, really important. And in our world, that's important as well in terms of doing that, because it really is about the stability by implants leads the need for the race to the surface for preventing infection, because you got to get the eukaryotes to bind And that's why this time to implant, I think, is so important. And that Marcus Godina and Bhopal said, and we're finally catching up to them 30 years later. And Paul Tornetta's data that cutting down that time makes sense, and the data seems to indicate that that's important as well. And don't forget about the other factors. It's not just about us, it's about everything else, and try to support people in that or have a system for doing that, because these are all the little things to stack the deck, or everything all the time, all at once. And glycemic control, and use things we control, the things we can, and maximize the things we have a harder time with. So that's about prevention, and I think there's some interesting things going on. I think, as Ted alluded, I've done some work on diagnosis, in that if you can't diagnose something or define it, you can't really study it and communicate. And a systematic review of infection studies in orthopedic literature and orthopedic trauma literature found that only 2% really defined it. I mean, that's embarrassing. And so what is it really? So a number of years ago, that the AO group started putting together a number of people to try to help define it. And it resulted in this, in terms of how you define what an infection is. I had used the CDC definition and thinking it's the CDC definition. The reality is, in terms of criteria, number 4 is surgeon thinks there's an infection, which isn't so precise. And it throws out everything except for 30 to 90 days, because the CDC is a surveillance organization of hospitals in North America. And that's really their focus. And we talked to them last July about, their definition, and are they interested in more of this definition? And they're lukewarm, and they're like, we'll get back to you. And they haven't really gotten back to me yet. So we'll talk about it. So this is really the confirmatory criteria, using that, and this has been verified prospectively to be 98% predictive of a deep infection. And the CDC definition misses half of the infections, because half our infections occur really early or occur really late, or they don't occur. In CDC only applies to long bones, but it's, everywhere we cut, we can, officially it can work. And this is the document that says it's only 50% effective in picking up CDC definition. So just 2 weeks ago, I had a meeting with I was representing the AO group, or these groups, with the WHO, and they seem really interested. And the problem that the CDC also doesn't define open fractures that get treated closed or non-operatively. And that's a huge problem, the LMIC, low middle income. And I think this IOTA thing is a great thing. And they seem really interested, from emails yesterday, to really continue this discussion and consider endorsing. And if you define it, you can study it, and they will use that definition in their lexicon and their publications. They're not going to go through the process, but we'll work with them to hopefully maybe do that and make that more of a worldwide accepted definition. So in spite of prevention, sometimes you're going to lose, and you're going to need to come to how you treat them, because we've all been there. As I said, I've created lots of these, and why I think it's really important to try to figure out what's the best way to treat them. And in any principles, it's, debridements, antibiotics, stability. Stefan Perrin showed us that, and then soft tissue coverage and/or blood supply, and how you get that there. They're the basic principles, and just you ought to tick through your mind and how you're doing that, and that you're applying those principles to everything you do, because we're all going to see this. And that people often ask me, one of my favorite publications that we wrote is that bicondylar plateaus with dual incisions have a 22% infection rate. This is a few years ago, but I think we're maybe a little bit better, but it's bad. We should do better, don't you think? Your total joints is 0.05, and you're upset. And we got 22 and reproduced. And Bossy was like, oh, you guys are really shitty. You're bad. So they redid it, and theirs was 23. So that made me feel better. But it just, the reality is it's high risk injury, high risk patients, and we do high risk things. And sometimes maybe we operate on them when we shouldn't. But I think we just know we got a lot of work to do, because you're going to have that. We talked about this. How do you know? So the debridement part, how do you know what's dead? So I'm old enough, I've done some tetracycline, look at turning off the lights and cutting out things that aren't lighting up. This Woods lamp or laser Doppler, Mark Smokowski taught me about that. And he wrote a bunch of articles about that. And does it really work? It certainly works. He had good results with it. I think we will see some of this SPY. I think our plastic surgery friends are doing it for flaps. We may use this, or we may use PET scans to better determine, but transmitting a PET scan to the OR in terms of what's really alive is hard. And sometimes you just need to cut out that chunk of bone. I try to avoid that if at all possible, but sometimes you have to give patients a chance, because you got to get rid of the dead stuff because it's colonized, and you're going to have a heart. You can't get blood flow to something that's dead. That's why, that's why it's important. Or just use your eye. Well, maybe you have to compare the SPY and the eye and the laser Doppler to an experienced eye. It really may not be different, but I think we will see a change in the imaging and how you define it. And this is the article, I think, which is really interesting, of using the SPY intraoperatively to determine, like we said, what are you going to do differently? We may be doing this, and what's alive, what's not, using sort of SPY technology. And it's going to be used also. We're doing another study of using it in necrotizing fasciitis to determine where the tissue is alive and dead, is another, I think, unique use in it. And the tumor surgeons are using it also in terms of what's alive, what's dead, what's been damaged by chemo or radiation as well. So I think some interesting things you're probably really going to see. But in general, I think being more aggressive is better than less aggressive. So when in doubt, cut it out. And how we determine what that is, I think we're going to maybe see some new technology and help us figure that out. Cultures, if you have it, the current recommendations from ours is send 5 swabs, 5 culture specimens of tissue, no swabs. I still get handed swabs in the OR, and some of my colleagues still send swabs. But the Infectious Disease Society of America in 2012 said, don't send swabs. Why are we still doing that? This stuff is written. We don't always follow our own recommendations. And like we talked about with the RIA is 15% of the time it's been different. An article we published in 2020. So it's a good debridement tool and a good bone graft tool. Is designed as a prevent fat emboli tool, which we hardly ever use it for that anymore. But that was really its origin. But it has other uses as well. So don't send swabs. So back to our friend. What are we going to do with him? So you get this, and who's going to heard this commandment 11? You must remove all implants. That's commandment number 11. And I told a story yesterday that, I at the AO meeting with the audience response, that 88% of people said take them all out on that bicondylar plateau a couple weeks after I put it all in, and I couldn't believe it. So we wrote that article, we reviewed of, one of the ones that, if you have an implant and it's been early and you have a culture positive, that if you have plates in, 80% of the time they can stay till union, and nails it's 50. So it's just one other piece of information, how long it's been, to decide do you have to take the implant out or not. So again, there's no time cut. And in our fracture-related infection, there's no time cut on that. It's either is or it's not. It's not 2 weeks, 6 weeks, 12 weeks. It's a spectrum, is what I think the follow-up study showed on this. And this is the study, the first one that and basically the other one's about the same. It's just the earlier you get to it, the more likely it is you can eradicate to union. But still, many come back late. People say, is it gone? I said, it's gone for now. I mean, I've seen it come back 8, 10, 18 years later on people. And what sets it off? Who knows? We don't really understand. So hopefully we will. But this is the article we talked about yesterday with this critical analysis. And this is just the thing to keep in your mind. This graft it's a spectrum. So again, the sooner you find it, and it's probably somewhat organism dependent and host dependent, but it's one other piece to put in your professional decision making on what you're going to do to take care of that patient. Just think of that spectrum. And do you debride and retain? Again, plates 80, nails 50, something you can just keep in your mind, and results worsen with time with that. And there's no longer these cut points, arbitrary cut points. And with that, do you keep it or do you not? And the total joints has taught us to do 1 stage. And does that really work? 2 stages. See, some of the data, if you look at it, seems to be about the same. Or I know people in the trauma world that do 3 stages. Mike Sirkin, he'll talk very adamantly that you do a debridement, and then you come back, you do a biopsy, and then you do your fixation. Although he says that he's had no positive biopsies in 14 years. So I don't know if it's necessary to do that or not. It may go back there. Maybe when you have that spidey sense that you should, it doesn't mean you never do. You just maybe not always routinely. You have clearly made a good decision with doing that in a stage fashion. But those are just the options. We don't know which one's better. Ted, do you ever? What are your thoughts on single versus dual stage infected joints?
Still a work in progress, and very tailored
So similar, an option, right host, right bug, right patient, right scenario, maybe a reasonable cure, reasonable option. But again, that's the work for you all to help us continue to figure that out. Same in knees or hips. And so what are the tools, at least in our world, I think, that help deliver local antibiotics after you do your debridement? That anything to do with the company, but I think it's the best we got now is deliver them, and because antibiotic nails work, and there's history, but it's not a great way to deliver antibiotics. When deliver antibiotics, I think this is a great way to do it. I call it the Pez dispenser. You sort of make those little things and you pop them into here. You can put that in the canal. You can see where it is on the in the tibia, and a little marker. And or you can make your antibiotic nails. You can inject them, which I have the video on how to do that, or you can roll them. We actually did a little trial just for the OTA. Willem Metzemacher, my infection friend, we had a number of people roll them and inject them. And I was the injector and the promoter of the injector. Rolling was better, I think, in every category. We haven't done the elution data. We're getting the elution information back. And is there a difference in the elution of those nails? I think that difference may not be that big a deal, but we had better reproducibility of nails with the rolling technique, although I've been an injector always when I do it. And this is on the OTA website. It's a sweet video on how to do it. And this is the recipe of stuff to use on how to do it, how you make it. There's some other recipes out there, but this is, and I don't use chest tubes. I use the perfusion tubing because it doesn't melt. Chest tubes, some of them, depends on the company. Some melt, some don't. So the perfusion tubing doesn't melt, and it can be 1/2 inch or 3/4, depend 5/8 or 3/4 inch with that. Oops. Oh, my video. Oh, I was gonna make. Sorry, my video is not playing. Too many copies. But that's the rolled nail. It works. And then again, in December of 19, I was at this AO anti-infection meeting. I said, why don't we have what our friends have with these Prostalac spacers? And so this is the initial project I put in the DPS website for an investigator-initiated thought process. And this is what was at the Academy last spring. And this is what I saw in last December in Davos. And it's a sweet thing. It works really well in terms of going in. It's got a nice coating. Engineers are great people, but Dr. Vail, the BME engineer, and the engineers for DPS helped design this. But then I just learned a couple months ago that this has been approved in Europe and since June of 2021. Looks pretty similar, shockingly. But Synthes is still going to push forward with trying to put together their antibiotic coated nail through the FDA here. So we've been talking about antibiotics. I haven't really been talking about giving them to people yet. And this is the recommendation. We can use them locally, but then how do you deliver them to patients? And do you even need, this is commandment number 12, thou shalt give antibiotics, IV antibiotics for 6 weeks. And I told a story last night or yesterday that, our ID team would always say, take all the hardware out and give them 60 antibiotics. So we really fired them for a number of years until they came back and said, okay, we won't say that, and we'll give you a consistent group of people, and we'll talk to you before we make recommendations. And so we've got a really good working relationship with our infection team now. So why is it that we give 6 weeks of IV antibiotics? Why? And this was my question as a junior resident at Children's. Mo, he had to go. He told me that. But I'm like, why are we torturing these kids and these families with IV antibiotics when their parents are going to give their kid the antibiotics? Oh, compliance is better. Let me tell you the data on PO versus IV compliance. There's no difference in the way we can measure it. We haven't written that, but I have the data to support it, as I saw that just this last week. So this has been the commandment. But really, this is a clinical infectious disease. This is I like to show them this article from 10 years ago, that oral and parenteral antibiotics achieve similar cure rates. Oral have associated risk with IV catheters and infection. So you don't have that. So, and PO is less expensive and a reasonable choice in worst case scenario, osteomyelitis. This is the ID literature. They don't believe our literature. I said, well, here's yours. Nor is it new. Mark Swankowski, when I was a junior resident, we were doing this, and he was giving people IV antibiotics are in the hospital and send them home on PO antibiotics. 91% cure rate. I think any of us would love to have that. So why is it in our lexicon or our dogma that you have to have 6 weeks of IV antibiotics? And as Ted, maybe it's probably shorter. Swinkowski has another series of 2 weeks versus 6 weeks with no difference, as does Cheerney in his, in the hospital, 2 weeks and 6 weeks were all the same also. In data I've seen him present. He never published it, but I think they couldn't get anybody to publish it. So that's a little bit of dogma. And so hopefully we're changing from IV to PO, and maybe you guys can take it down from 6 weeks to a shorter period of time until the implant is protected with eukaryotic cells. That may be what's important. But this is the Oviva trial out of Europe, which is a combination of total joints, spontaneous osteomyelitis, and fracture-related infections. And they had over 1,000 patients in that, and it has a little New England Journal publication showing no difference in reinfection rate or reoperation rate for IV or PO. And I was the PI. One of the first metric studies was this PO versus IV antibiotics and in fracture-related infections. And we presented at the OTA, and this is our reinfection rate of 30%. You'd think we'd be better, but this is just the data. And it's the same with PO or IV. And that's true in intention to treat and in per protocol for reinfection rate. Then the primary, this is where we hope this is ready to go to New England Journal also. We're having a little bit of an internal fight because if you do per protocol, I mean, what they got, we had a lot of people cross over from IV to PO who are really high risk patients because they couldn't send them home on IV. So those high risk, those 19 patients that got crossed over, they had a pretty high reinfection rate. So the reinfection rate didn't change, but the number of operations went up, and there's not a difference in reoperation rate, number of operations, which was our primary outcome measure. So we're having a fight with statisticians about how to present that. But I think we've finally accommodated, and hopefully that'll be another New England Journal supporting PO antibiotics. The hard problem has been these culture negatives, like you think it's infected. And like I said, 80% of bacteria in the world aren't culturable with our current 1920s techniques. And maybe NGS will be better, but I think we're yet to prove that. But we're trying. That's a part of some sub-studies. The next sub-study we're doing with PO versus IV antibiotics from conversations yesterday. We're going to decide to tack on some NGS study on our next race. Because I think, as I said, it's been about the race to the surface, whether it's total joint, spine, or fracture-related or infections, or sports with your, resorbable stuff. Because biofilm is the problem. Once you get a biofilm, it gets really hard to get rid of because they're low active. That antibiotics don't get into there, and your white cells can't get in there. There are some things that can get in there. We'll talk about that in a minute, and they may be helping in the future. But this is, I sat down to read this one day, and I don't know, 5 hours later, I was fascinated how great the information was. But it was aha moment also for me that bacteria in the world live in a biofilm state, like 90% of them. And it's like the tip of the iceberg is what we see. Most of them are not in planktonic, meaning live and active, but in a senescent, a biofilm state. And like bacteria on the table here or on your skin, most of them live in a relatively quiet state, looking for an opportunity to then take off. And so hence we can't culture them, and nor do we know there, but we can find them with NGS because we break them down. And these people are trying to develop some cool stuff, some biofilm compounds. My guess is this isn't going to play either. That's too bad. But this is a Petri dish, and it's washed with this substance, this compound A. I don't know what it is, but it just eliminates the biofilm off the Petri dish. And so these are coming to market for maybe to help us retain implants and prevent infection or joints. If you can wash these joints or metal substances and eliminate the biofilm, that may help us in treating the infections. So I think that'll come because biofilms are resistant to antibiotics. They don't really grow. And you can't, and our current bacteria can't get in them inside the fort, and hence why you got to protect the implants. But we will see different coatings. I mean, there's even the sintering of it is important in terms of whether planktonic or eukaryotic bacteria can do it, and some are passive like that, and others are active, like barbed wire or even antimicrobials on the implants. And that's coming because we know it works. I mean, every central line that goes in this hospital is coded, is my guess, right? And it cuts down the infection rate. So doesn't it make some sense that in high risk scenarios that we do the same? And these are out there. They've been out there in Europe, these gent coated nails, for 10 years or more, just over 10 years, right? They were released in Europe, but I'm still shocked there's not great data on these, the ProTech nail. And we've been trying, and there's some small series, but again, this is, the largest series of these 99 patients. That's really nothing in terms of really proving that they work. But there is a new competitor coming. I just learned about this a couple weeks ago. This anti-infective, they say it's antimicrobial, it's preventive, not therapeutic. And it's palladium, gold, and nickel. And it works by creating electrical charge, so they say, on the outside of the nail, to prevent adherence of the bacteria. And it's something similar to galvanic corrosion. So we tried doing a ProTech nail in the U.S., but the FDA wouldn't let us do it because they say it's a drug. This is a gent-coated nail. So getting drugs through that mechanism are hard. Where you're going to see something really interesting is these bacteriophages. This is, I think, coming back. This is the 1940s and 50s. This was, being explored, but then penicillin happened, and then World War II happened, and antibiotics basically cured, but they worked for everything. Penicillin was great, and the research on this just went away. It was starting to come back because of this MDR. And in January of 2021, the Belgian government allowed prospective trials on this and controls the use. And there's some new prospective data coming, but there's some literature that bacteriophages, so bacteriophages are the natural hunter killers of bacteria. They're naturally occurring thing. They're everywhere. But you can select them like you do antibiotics. If you have a bacteria, you can see which bacteriophages kill it and then select for those, grow them, and then inject them. Think about for total joints. What a great idea. Huh? I mean, you can just inject bacteriophage, and then when they're done eating the bacteria, they go away. Or you can give them systemically or locally. It's really fascinating. The problem is there's no SOP, no standard operating procedures. We don't know the dose. We don't know how often, but we're starting to try to figure out. And my guess is some people in this room, you'll be doing this. And industry sees this. This was, last March was a industry-sponsored bacteriophage conference. That means they see money in the market, and they're probably right if the WHO is right that MDR is a huge problem, because these bacteria don't have a defense against bacteriophages. They can't develop a defense against bacteriophage, and they work systemically. And this is just a study shows that it's feasible, and because I think that you'll see this in the next 10 years, but not tomorrow. But I think it's one of the most interesting things in terms of treating infections. To me, it's about the team. That's, I've been a team sport guy, military for, and ortho trauma is a team sport, but so is infection treatment is a team sport. And they're not your enemies, they're your friends. So we have good relations with our ID people, the anesthesia team. It just takes a whole team, our plastic surgeons. Have your conversations beforehand so it's not a contest, it's a participatory and collegial process for these complex problems, because they're hard, they drive you crazy, and they stick around a long time, and they become your friends. I mean, the patients who get their treatment and they're gone, I mean, these people become your friends, and they they bring him wine, they bring him things, they bring me chickens and pigs. But I think it's a team. It's really important. And again, make a diagnosis for the summary, take your cultures, send tissue, work on your host, pre and post. Implants, we don't single stage, 2-stage. Most of ortho trauma is done in 2 stages, but like I said, Swinkowski's got a nice single stage series that we hope we could replicate. Total joints, it's in evolution, and maybe with the right patient, it can be done. And then give them antibiotics locally or antimicrobial locally, systemically, at least for a little while. And I don't think it matters, PO or IV, and hopefully your ID docs can get on board with that. Not until after we do our infected non-union study, though, because we still got to randomize them in that study. We're starting next month on that. And prevent or attack the biofilm in terms of what you're going to do to maybe eradicate them, or maybe that they're just not infected yet. They haven't come back yet. That's what I tell many patients. So I do think the future is bright. I mean, from the people that you all I went to dinner with, thank you. We've got a lot of opportunity. This is not nihilistic because I think everything matters all the time. And I hope that you take that as a philosophy for how you're going to take care of these patients, because the one thing that comes a negative impact on, talk about PROs and quality of life, it's having a complication, a non-union infection. And this is the most common complication that we in orthopedics get. So we ought to spend some time trying to prevent it and eradicate it. So anyway, I got some cases, but I'm done. We're done. Thank you. Questions?
So Bill, first of all, thank you so much for that comprehensive view. I think, so Bill, thanks. Now it goes. Bill, so first of all, thanks so much for that comprehensive view. I do think you do point out very well that this is a really big picture kind of thing. And you brought up Laurie Donners. So for those who don't know Laurie Donners, he was a orthopedic trauma person from Chapel Hill who just retired a couple of years ago. But he had all sorts of great ideas about this, most of which he would just bring from the hamster directly to the patient. But he said, you can be on the cutting edge of one thing, they'll think you're an innovator. You can't be on the cutting edge of everything, they'll think you're crazy. And that's part of what's going on here too, is that there's so much that's new and innovative. And you pointed up Cherny, and I didn't be able to get his paper published. If you were going to pick out one of these things to focus on, so local antimicrobials don't work in part because of FDA problems. It's the same thing that we've had with growth factors. If you're going to pick out one of these things that you think is going to make the biggest difference, what would that be?
In prevention?
In treatment of these
treatment.
FRIs. Yeah.
And in treatment, it's probably going to be phages in treatment in terms of efficacy, because it's a smart bomb. I mean, you select it for that bacteria and it goes and finds it and eats it and destroys it. So in terms of efficacy of treatment, it's going to be phages, I think, long term. In prevention, it's probably a local antimicrobial of some sort to smear it on the implant in the wound at the time. And whether that's this alkaloid from a sponge or a gent polymer it's hard to do one of these polymers are the gels in a huge acetabulum or a huge total joint, and that's where the irrigation may be better because it's hard to scale that. So in the prevention, I think it's going to be local, and in the treatment, it's probably going to be, because the phages can go up into the canaliculi where they go and hide. They can go places, they can go into the biofilm where antibiotics can't go and your cells can't go.
Thank you. All right. Any other questions or comments? Dr. Gill?
Bill, really informative, and a couple of things you said that really got my attention. One was you mentioned getting to zero, and on maybe the presence of bacteria. I want to challenge you on that one. The other one is you can't culture 80% of these, so we don't know what's out there. And the challenge comes from this new field around the microbiome, and you mentioned phages as maybe being, but maybe bacteria themselves are a therapeutic avenue, and understanding the microbiome, and maybe there are bacteria that live in these areas that are beneficial and not. And I'm wondering, in your reading of this, your understanding of this, your interaction with the ID people, and Chris Hernandez, one of our scientists here, is interested in the microbiome. Chris, if you're on Zoom, I'd love to hear your thoughts. But do you see the microbiome research being something that will shed some light on how we treat musculoskeletal infection?
Chris there. Yes, I think so. I don't know how. It might be that we learn to colonize with non-pathogenic bacteria, which then that's what protects, and instead of your eukaryote, but you colonize it with bacteria. If you take out pacemakers, they take them out, 10% are infected or are colonized. They're clearly not infected because they took them out for swapping them out. So is there a way to instead of inhibit prokaryotic cells, to include them in the microbiome, you intentionally put them on. That's potentially a brilliant solution. Have any research on that, or
Well,
is that what they're doing?
It's sort of this idea of adjacencies. We're seeing how other chronic conditions in medicine are being treated by understanding the microbiome and altering the microbiome. And you've got to believe, and I'm sure there are people in the audience that are more expert on this. I have superficial knowledge, but that there's got to be some application there that's relevant to what we're doing. And I like to look at
altering your microbiome in your gut, and altering the microbiome in your skin, and altering microbiome on that implant are all probably potential avenues for doing that.
All right. Well, I think in light of time, we'll wrap up there. But Dr. Obremskey, thanks so much for being here. Very impressive work and great talk. So thank you.
Well, thank you.